Good morning. I'll try and share some thoughts on non-invasive assessment of liver fibrosis and portal hypertension. I was a bit surprised that there is no second speaker, and I had requested Seema that there should be someone, but somehow they dropped out. I have nothing to disclose. I have tried to update till yesterday whatever is published. I have divided the talk into two parts: non-invasive assessment of liver fibrosis and then of portal hypertension. This is a rather old slide but important. The fibrosis assessment is important because as the stage increases, the decompensation means appearance of ascites, jaundice, encephalopathy increases. And fibrosis is associated with portal hypertension, HCC, and need for transplant. Also, we need to assess fibrosis for response to therapies and whether fibrosis regresses. Liver biopsy has been a gold standard all these years. But the liver biopsy has some gray areas, and between F2 and F3, the concordance was only seen in about 30% of the pathologists. There was discordance in large, and there is a possibility of losing a person. This also old study is important to tell you how the fibrosis progresses. F0 to F1 is 0.117, means in 10 years, F0 will become F1, or an F2 will become F3 in about 8 years' time. In India, the stage of progression is about 6 years to 8 years. This we published several years ago. However, you will realize that these are not stage specific. This is the real cross-sectional. After a given period of time of 10 or 15 years, it can be an exponential increase. In fact, the rate of progression of F2, F3 and F4 can increase exponentially. It is not linear, it can be exponential. So this cannot be measured unless you have stage-specific biopsies over time, which is not possible. So biopsy is invasive, although a gold standard, but maybe somewhat imperfect, stage-specific, and it is non-continuous over years of follow-up. This recent paper by Dr. Sanyal says why should we have NITs, and three broad pillars: context of use, analytic robustness, and validity and utility. So context of use is purpose of use and population. So whenever you are in the next few slides when I present, try and analyze purpose and population. Then analytic robustness is reproducibility, that is ROC or others, and clinical validity, positive and negative predictive values. So there are tools: blood, elastography, and AI and machine learning. This is a very simple but important slide in the journey of chronic liver disease. So you have low platelets which continuously go down over a period of time. Albumin goes down, AST is more than ALT, hyperbilirubinemia and coagulopathy. They all go with advancing fibrosis. So there could be direct and indirect blood markers. Direct means they are involved in extracellular matrix deposition, degradation, or cytokine signaling during fibrogenesis, not fibrosis, fibrogenesis. So the amount of collagen deposited and amount resolved or dissolved. And these are hyaluronic acid, metalloproteins, matrix metalloproteins, and tissue inhibitors of metalloproteins. So these are important and we will go through them. The indirect markers correlate with histological fibrosis like platelets and AST, and there could be combined and proprietary and non-proprietary tests. This is not a difficult slide. This is used for NAFLD patients. The important is APRI, AST to platelet ratio. It is important that we realize it is only F3, F4. False positive in many. Fib4, which we routinely use in our labs, and the LFT at ILBS shows Fib4, is age, AST, ALT and platelets. It is also for F3, F4. It has low accuracy, less than 35 and above 65. The NAFLD fibrosis score NFS has age, BMI, AST, ALT, hyperglycemia, platelets and albumin. It also has only relevance for F3, F4 and again has accuracies which are charted by age. Now this is a recent paper in Lancet Gastro. Just pay attention, F3 and F4, this is based on liver biopsy. Now a liver biopsy, if a patient has F0 to F2, as I showed earlier, this guy will remain well for a long time. But if he has F3 fibrosis, it goes down over time, it may become, and F4 goes down faster. Maybe 40% of the patients will die by the time of 8 years or so. Now let's look at Fib4. Fib4 about 2.67 actually also gives you similar data, although F3, F4, the divide is wide. Let's take the liver stiffness, and you have a patient whom you have seen in 2010. He had a stiffness of about 19 or 20. Over 10 years, this patient is likely to go this way, and if the LSM was about 20, liver stiffness measurement, his journey is same. Now this and the liver biopsy are almost parallel. Just to emphasize that a carefully done liver stiffness and properly designed study, you will have almost similar outcome. NFS may not be as reliable as others. Let's go to other biomarkers, and this is my favorite, which is not done, procollagen 3 peptide. Every single molecule of collagen which is deposited, collagen 1 is a mature collagen, procollagen is pre-immature collagen. So when you convert from 3 to 1, one molecule of procollagen 3 is released. This is very emphasis. So one molecule of collagen laid down, one molecule of Pro 3C is released. This correlates very well, although it has not been validated and we don't have it. Should have some time. We have ELF score. Very recently Shirin has been able to get P3 peptide and terminal peptide, hyaluronic acid and TIMP1. Now this correlates well with F3, F4. In early fibrosis, it has not been so well validated. Let me show you some data on ELF. This recent paper included 6,000 people. These were in general population, run of the mill. ELF was done about 14 years ago and the patients are followed over 13.4 years. Those who had this enhanced liver fibrosis and the liver related outcomes were seen. An ELF value of 11.3 or more have 7% bad outcomes. It's a simple test done today and followed up over time. So what you don't need to do in a general population, you can't do a liver biopsy. Just do a blood test and you can follow. The same was done for, if you look at Fib4. The Fib4 was also followed over a period of time. So in my opinion, Fib4 could be good. ELF can also be good. I'll show you some more data. Now this is a combination of Fib4 plus ELF. This also just published. 3,300 people were taken, some from general population, those with alcohol and those with NAFLD. When alone Fib4 was done, you had a false positive of 35%. All these are false positive, misclassified, or false negative or less. And true positive were there. So Fib4 correctly classified 63% or 60%. When you add ELF to this, your false positivity rate comes down and you correctly classify 88% of the patients. So we need to have at least 2 tests today, Fib4 plus or minus ELF, if you are using general population or disease related population. So let's summarize this part of biomarkers. Biomarkers have low failure rate, means they will pick up but they may be false positive. They are reproducible, they are low cost unless they are on proprietary, and they are validated for fibrosis. The disadvantage is anybody who has hemolysis or using other drugs, it can be fallacious. They are affected by sinusoidal endothelial dysfunction. If there is some biliary excretion problem, they will be affected. They are not good for F2, F3, and the availability is low. Let's go on to other tests. First, define, these are new terms, but hepatology people know. For the rest, compensated advanced chronic liver disease, CACLD. It reflects a continuum of severe fibrosis and cirrhosis. So F3, F4 can be part of it. And liver stiffness is used to stratify, and it will help you define clinically significant portal hypertension, decompensation, irrespective of histological stage at point of care. Now both terms are used. We are generally using CACLD, and if the biopsy is there, we will say compensated cirrhosis. There are two methods. One is fibroscan, which goes straight. It is a low frequency ultrasound, or we can use RFA. Now this is a slide you must have seen 1,000 times, and this is the machine, and it is used as a transducer, and the sound waves go for about 4 centimeters deep and also 1 centimeter wide. So it covers a huge area. When you are doing it, you will do almost 500 times more than what a liver biopsy would cover. Can you identify this gentleman? Except hepatology people. This is Manoj. When we started in 2008, the first machine came to ILBS for doing fibroscan, and all of us, we were doing ourselves, so I recommend all the residents to do this. This assesses liver stiffness and fat. It does not assess inflammation. This is to show you that the controlled attenuation parameter, it is the attenuation of the sound wave by the fat. If it is less than 220, you are good. 250 is upper limit of normal, and 270, you are not a good donor. And 306 means about 33% is fat or maybe more. Fibrosis is 60 milliseconds, and it should, the sound wave normal would be 60 milliseconds. If it is stiffer liver, it will come faster. It will be 40 milliseconds, 8.5. It's about stage 2 or more fibrosis. I'm repeating it, but it is important. Fibroscan, ILBS is the largest, probably globally, with 4 machines available doing 24,000 fibroscans a year. Now these are new indices, Agile 4 and Agile 3. Agile 4, these are all given by Dr. Sanyal, but they had in September issue, there are letters which clarifies it further. Now LSM, AST, ALT, platelet, diabetes and sex. These are Agile 4. Agile 4, if it is used compared to Fib 4, LSM and Agile 4, you can see that the OREC is higher. It is better. Agile 3 includes in this age as well, and this Agile 3 also gives you higher. The advantage of using Agile 4 and Agile 3 over and above just LSM and Fib 4 is marginal. If you see this 0.89, 0.92. But it is good to know, but I think we can work with what we have Fib 4. They are useful for diabetic patients, so we should use Agile 4, Agile 3 for diabetic patients. And this is exactly what we were practicing is now also reproduced in the CGH current issue. Identify for NAFLD patients who are having metabolic risk factors like MAFLD, obese or hypertensive or dyslipidemic, or have diabetes, or ultrasound or any other method shows steatosis. This is to identify. Then you take history, then you do Fib 4. If Fib 4 is above 2.67, it actually goes into high risk. I would put it 3.4, but they are using 2.67. The intermediate FIB4 will go on to getting a fibroscan. If it is 8 to 12, he needs or she needs a biopsy. Above 12, you certainly need assessment and treatment. Now, this data is for now Hep B. We have done with NAFLD, Hep B with normal ALT or with elevated ALT. Normal ALT above 9, patient will have generally need for treatment. Between 6 and 9 is a gray area, do a liver biopsy. In fact, we should do biopsy in most of these patients to age the virus and the fibrosis. Now, if the patient has an ALT of 110, then a score of 12 kilopascal is required for treating straight and screening for varices. Anything above 11 will be a high risk for liver cancer. 6 to 12 is a liver biopsy and treatment. Now, this is an important old slide. If patient has chronic hepatitis B and the LSM is 13 to 18, the risk of developing cancer per year could be about 10% or more. And if it is 23, it is much higher. In 3 years, 30% or so. In hepatitis C also, the cumulative incidence about 10, it starts increasing, 15 to 20, and you have increased incidence. So please remember, liver stiffness not only is to assess fibrosis, but the risk of development of liver cancer. Is LSM reliable in autoimmune? Not so. In remission or not in remission, response to therapy, the benefit of having a cutoff of 12 or 14 or 16 does not really help, and we need much more work. Also, reliability for portal hypertension is not there. So wherever there is inflammation, alcohol, autoimmune, or wherever there is cholestasis, these tests are not reliable. In alcohol, there is very limited data. Fibro test, AB, these are the areas where fibro or ELF can work. There you will have probably some reliability only for cirrhosis. And they have given a cutoff of 9.5 and cirrhosis 12.5, but much more work has to be done. What are the other limitations? If the patient has obesity or skin to liver thickness is more than an inch, ascites, heart failure, or there is alcohol, or there is steatosis due to other reasons like drugs, cholestasis, high iron, or patient is not fasting, fibroscan may not be reliable. So this is Baveno 7's recommendation. If the patient has more than 10 kilopascal liver stiffness, repeat it in fasting at least once and complement it with serum markers of fibrosis. FIB4 should be more than 2.67 or ELF of more than 9.8. RFI, we are using it in radiology department. This only gives you a different way. It measures the lateral shear wave velocity and measures, these are small regions of interest where you can place your cursor well, and these are the RFI's values, F2, F3 and F4, and they are quite reliable, can be an alternative if they can be used well. Just published this month is MR elastography. Now MR elastography we started but we could not achieve, is an important tool. Now here 798 patients from 8 international cohorts. Just to tell you, all the green is good, all the red is stiff, hard liver. So it varies with the color, yellow is in between. Now the cutoff given for RFI by MRI elastography is F4 is 4.45 and the reliability is 0.94. And for F1 it is 0.82, 2.65. The problem again comes in F2, F3 where there is a huge overlap in this. Also, if the patient has high gamma GT or patient has high ALT in other ways, this cannot be considered a very reliable thing. So let me summarize the fibrosis assessment as of now. The NITs are reliable to predict that this patient needs a biopsy. 2, it provides you a continuum you can do every day, every month, every year, and can predict possible outcomes if it is worsening. Early fibrosis can be picked up in general population. You can't do a biopsy in them. ELF is probably more reliable than F4. We need to test. And liver stiffness may be as good as MR elastography. These tests are less reliable for F2, F3, less reliable when F3 becomes F2, especially for clinical trials, and we don't have etiology-specific cutoffs. Maybe combinations of blood and TE are better. This is what we have been practicing for almost 10 years, and these are now, in a way, national guidelines. NITs for national programs. So primary healthcare worker at PHC will do FIB4, and if FIB4 is equal to or more than 1.3 or NFS is more than 1.4, then this patient has intermediate to high risk and patient is to be referred for a fibroscan. Just to remind you, NFS is more reliable in diabetics. And of course, if it is less than 1.3 or NFS low, this patient needs no further treatment except 1 year. Now we'll go further on this, and this is what the proposed ILBS protocol for MAFLD was and is: assess hepatic fibrosis by elastography. If it is 8 or more, then intermediate to high risk, patient can be considered for liver biopsy, can be given therapies, and new drugs which are on trial can be given, lifestyle change and diet is prescribed. And if it is high, he goes for other tests. Now I briefly will cover portal hypertension. First, what is the importance of clinically significant portal hypertension? Why do you call clinically significant? Now, if the normal liver pressure is 5, if it becomes 10 or above, this is a scale given by Abraldus. If the patient has an HVPG or liver portal pressure of, let's say, 13, he will have in 3 years chance of about 18% to get decompensated. Very interesting work done by Dr. Jindal is an analysis of a very large group of patients. Patients were divided into those who had 20 or more HVPG and 6 to less than 12 HVPG. This blue line shows you over 2 years decompensation in 11%, and in this 45% or so. We divided it further. Between 6 to 8, 5 is normal, 6 to 8 and 9 to 10. If the patient has 6 to 8, even then, this is subclinical, even then 9% will decompensate. And if it is 9 to 10, still subclinical, 1 in 5 will decompensate. So the bottom line is anything above 5 is not good, 6 and above subclinical, but they have relevance. So we should define this again. Don't put it at 10. I would say portal pressure of 8 or above is bad. It can cause hepatic decompensation in 1 in 5. So we should start reducing it much before varices develop. These are the conventional methods of assessing: endoscopy, doing an HVPG, putting a balloon catheter, wedging it, so it gives you wedge pressure, let's say 32, then deflate it, it gives you free pressure, and then the difference between wedge and free will give you that yes, this patient has 21 millimeter of portal pressure gradient, and this is more than 10 is significant or so. Now the question first is the CSPH important? It causes decompensation even above 8. Are their tests reliable, non-invasive tests? So I'll propose blood test, elastography, MRI, some radiomics. Now the hematologist and pathologist know very well, you have collagen layer and you have the subendothelial, and then you have sinusoidal endothelial cells. Now whenever there is an injury here, like in this case the endothelial cells are lost, which is common in cirrhosis, you will have the exposure of von Willebrand factor in the tissue coming out. Platelets will come and collect here, and then platelets will make a plug. This is the function of von Willebrand factor, which is released by activated endothelial cells and helps in clotting hemostasis. This has been used as a marker of portal hypertension. I can't go into details, but increased von Willebrand factor means there is a platelet plug and deficiency, so more and more of this is to compensate the function and number of platelets. Now, this has been done. If HVPG is less than 10 millimeter, your von Willebrand factor levels are around 190 to 200. But if HVPG is more than 10 or equal to 10, the von Willebrand factor is above 305 or so. This is very interesting study just published. In control, von Willebrand factor may be about 150 or so. HVPG 6 to 9 subclinical, it starts increasing. 10 to 19 about 300, and then about 20. There is not much difference, but it can tell you clinically significant portal hypertension. So now world over we believe 315 von Willebrand factor antigen is good. This tells you the N-terminal peptide. The N-terminal peptide need not be done. You can just do the antigen. You may need to do activity, which is a separate marker. This is dependent on ADAM-TS, which breaks down the von Willebrand factor. It also may not be there. So a ratio of this to this is probably important. To put it in simple terms, von Willebrand factor antigen correlates with degree of portal hypertension. Let's come to liver stiffness and its relevance for portal hypertension, not fibrosis. LSM above 25, clear. This is portal hypertension. LSM above 20 with a platelet count of less than 100,000, clear. But between 100,000 to 150,000 platelet is the challenge. So this study, which is analyzed by Dr. Ashish, he analyzed 26 studies, about 4,000 patients, where HVPG and elastography was done. And the data is anything about 22.8 gives you clinically significant portal hypertension. So we had picked up at 25, it can be even slightly lower. This is what Bavino 7 said. Anything about 25, it is clinically significant portal hypertension. Above 20, you require platelets of less than 150,000. I would say extend it here, even if you have an LSM of 15 or 15 to 20, but platelets are lower, I think it's a very important marker. I will assume it to be clinically that this patient has ACLD. So remember this part of platelet and LSM. Important is if it is less than 10, there is no worry. So are NITs reliable in diagnosing CS, PH? Possibly yes. Let's look further onto the spleen side. The spleen stiffness reliably reflects portal hypertension. Here is a spleen. How congested, how stiff is the spleen? And this directly reflects portal hypertension. This reflects the fibrosis, but may not be so reliable for portal hypertension. Now we have from last 1 year the most advanced version of FibroScan 630. The old version 530 had a range up to 75 kilopascals, and here the range is up to 100 kilopascals because spleen can be stiffer. You require 10 valid measurements. You need a region of interest, possibly no. It has been cleared by FDA, and you can do SSM and LSM both with this machine. The Bavino 7 recommended that anybody who has a spleen stiffness of less than 21 has no CSPH. They have not defined what is normal, and we have to define it. But less than 21, patient with cirrhosis, no need of endoscopy. If it is above 50, yes, do endoscopy. So let's revise this part. if the patient has a liver stiffness of more than 25 or spleen stiffness of above 50, this is clinically significant portal hypertension. So the rule of 5, 25, 50, less than 10, nothing. Up to 20 and above, but platelets being low, portal hypertension. Above 25 with liver stiffness, yes, spleen stiffness above 50 predicts. Now, we have defined this part. Now, prediction of variceal bleeding. I'll give you some data from ILBS. This work again done and led by Dr. Ankur and Dr. Manoj. This was liver stiffness, HVPG and FIB4. In this very large series, please pay attention that patients who have got HVPG above 10 and liver stiffness above 22, this pink line. These patients have decompensation over 6 years, almost about 50% or so. What is important is those patients who had a liver stiffness about 22 and HVPG was still less than 10, subclinical, but the liver stiffness was about 22, the decompensation rates were quite high. They were almost about 35 to 40% will develop ascites or jaundice. So therefore, it is important that we just do not have to do HVPG in all, we can do LSM of 22. Based on this, we propose this decision curve analysis. Decision curve analysis is those who are above 22 should get treated, and this will cover most patients. This is in tune with what earlier meta-analysis of 4,000 patients were there. So we would say 25 certainly, but we may lower the bar. Now this was the first study done by Praveen when we were lucky to have him with us. When we were doing spleen stiffness with the 75 megahertz probe. This was published. This is the first study in the literature in radiology. Here EHPVO, cirrhosis and controls were taken. Liver stiffness was done and spleen stiffness was done. The spleen stiffness was less than 20. Bevino says 21 and above is CSPH. I would say spleen stiffness of 20 should be up to normal. Patients with extrahepatic portal vein obstruction had 80, and those who had cirrhosis had fibroscan value of LSM of high, and the EHPVO, normal side liver, the fibro was low. Now this is important to say, patients who had bled and patients who had not bled. Those who had bled, spleen stiffness was 30, and those who did not bleed, spleen stiffness was low. This is not cirrhosis, this is extrahepatic portal vein obstruction. Now, Hitesh had very recently, but not published as yet, presented his data for his thesis, and I thank him for providing me this data. Spleen stiffness alone was done for non-bleeders in cirrhosis, non-bleeders in non-cirrhotic. The non-bleeders here are 55. This is the new probe. And in non-cirrhotic it is 70. And spleen stiffness in bleeders from 55 has gone to 79 and non-cirrhotic to 90. So bleeders and non-bleeders, cirrhosis and non-cirrhosis can be differentiated. This is the title of his thesis, and Dr. Ankur is the guide. Correlation of LSM and SSM with variceal bleeding in cirrhotic patients. Liver stiffness 51 and spleen stiffness 81. In gastric varices it comes down. And correlation of LSM and SSM in non-cirrhotic, liver stiffness is 5 and spleen is 91. So you can differentiate without biopsy cirrhosis and non-cirrhosis. This is a study done by Hirsch and presented, the Xavier study. Baseline spleen stiffness of 70, liver stiffness of 46, correlates very well with HVPG and predicts liver-related complications and need for beta-blocker therapy. So by and large, we are clear that 70 and above is bad for predicting that this patient is likely to bleed cirrhotic. Now, This is again coming back from the data by Hitesh. This is just to show you spleen stiffness of 70 has a good sensitivity and reliably measures with 16 millimeter of HVPG. This is cirrhosis. And here spleen stiffness of 75 is good and liver stiffness of 5 here is good. So these are now, but this has to be published. Let's see whether we generally give beta blockers and do 2 or 3 times HVPG, 6 weeks or 3 months or so. Can you just do non-invasive tests? So this is von Willebrand factor to predict the efficacy of reduction of pressure by beta blockers. And in this study, 159 patients were taken, von Willebrand factor was assessed. Those who had more than 5% or equal to 5% decrease were considered that the inflammation has gone down and they were considered as responders. And those who responded had a better survival than non-responders. So instead of doing HVPG, we can simply do von Willebrand factor. They also showed in this study a model, and they showed that HVPG in responders, the LSM in responders, and spleen stiffness in responders correlated with this. Bavino has said the consensus LSM of more than 20% decrease or coming to less than 20 kilopascals or any decrease to less than 10 is good. It means beta blocker is effective. Can it be done for primary prophylaxis, preventing first bleed by assessing response of beta blockers? So these two studies, one is with MR Elasto, one is with RFI with a small sample size. Spleen stiffness did not correlate with HVPG and very low ability of LSM or SSM. This is study done by Akhil. Thesis has been submitted, so I am grateful to use his data. 137 patients. In them, EVL was followed by HVPG. These are all acute bleeders who came, and there was done, HVPG was done at baseline and then at 6 weeks to see whether beta blockade is effective. 56% responded, 60% no effect of beta blocker, 81% not responded. Now this is the spleen stiffness. Now here you can see non-responder is blue. Non-responders, SSM did not, but here responders, the spleen stiffness decreased. LSM also, here it is decreased, and an ROC was developed. According to his data, a spleen stiffness, if it is reduced by 10 kilopascal, from 70 to 60, 80 to 70, or 6.5% reduction, or liver stiffness is reduced by 6.6, 5% reduction, this is a very effective beta blocker response. This needs to be published, but at least it gives a way. But here spleen is 10 kilopascal, which I doubt is easy to achieve. This study was done by Dr. Amar Mukund, Budd-Chiari syndrome. Pre-intervention liver stiffness was high, and you have put in the dips or dips probably. Then post-intervention, the liver stiffness comes down. You don't have to do portal pressure again, HVPG again, maybe. So stiffness does correlate with portal pressure. There are 2 ongoing studies at ILBS. One is by Chandan, who is doing non-invasive tests for assessing degree of fibrosis and portal hypertension, 2 parts, in patients with alcohol-associated liver disease, and Onkar, who is doing spleen stiffness as a measure to assess response to beta blocker therapy. There are studies done by Dr. Chitranshu in ACLF and maybe by Ravi. These are ongoing studies. I'll briefly touch with you MRI and radiomics. MR elastography, liver stiffness correlates with HVPG. I showed you a data, and spleen stiffness and HVPG correlate. This data shows you an important that those who were responders, the liver stiffness decreased by 0.4. This is a very narrow range. And here in non-responders only 0.1. relative decrease more, spleen stiffness a little more, and relative decrease in spleen stiffness was very little. So I still feel MR elastography has a place, but maybe our spleen stiffness is good enough. Radiomics to see portal pressure. This is the augmented, artificially developed HVPG. So you have a CT, and Dr. Shalini was working on this along with Ashok. Hopefully we'll have good papers on that. So here you can see the radiomics features, HVPG, and this was correlated. A model of machine learning was developed by these people, and the model was first done. Then you have a stage 2 where you go back, outputs were measured. There's a lot of clinical and radiological details to show you the results. This augmented or artificially developed HVPG and the true HVPG, there was a good correlation for 10, 12, 16 or 20. And here you can see the positive predictive value was good and negative predictive value was low. What does it mean? You have done a CT. The CT goes to the machine. You develop radiomics and say this portal pressure is 14. Are you reliably predicting? Yes. 9 out of 10 you may be correctly saying just by doing a CT. The computer vision, and this is just to say we were on machine learning. Then you go to deep learning, which is a subset of machine learning in which multi-layered neural networks learn from vast amount of data. And finally computer vision, where you have subfield under deep and machine learning that allows computers to understand. This is Mona Lisa. Now you do all the work, the nose, the lips, the angles, they all can be, edges can be done, and finally you get Marilyn Monroe, not Mona Lisa. And here you have varices. So now by computer vision you can do varices, you can do the red color signs and bleeding risk by this. This is a summary of what I have said, and this is by Thomas Reiberg, beautifully done. You have to suspect clinically significant portal hypertension. You can do by biopsy, you can do by HVPG, you can do by plasma biomarkers, von Willebrand factor antigen of more than 315, APRI of 0.876, the expanded enhanced liver fibrosis test of 11.1. We are not doing ICG for these, but ICG retention at 15 minutes of 16.7%. Liver stiffness above 20 with platelets low, 25 at any time, and spleen stiffness now of 50. So NITs in portal hypertension, the ILBS protocols I have just showing you now. These are proposed and they can be debated. I would say we should be using von Willebrand factor more and say that above 315. ELF, hopefully we can start evaluating soon. Liver stiffness above 25, I would say start beta blocker. We can do an endoscopy or can start. Above 50 liver stiffness, the high risk of bleeding, we should screen, do therapies. And if you have given beta blockers, less than 6.6 reduction shows probable response. Spleen stiffness above 50, do endoscopy. Above 70, high risk of bleeding, monitor. Any response of less than reduction in 10 kilopascals is the response. MR elastography, hopefully with the new machine we can set up. Cirrhosis versus non-cirrhotic, we should use it for differentiating. Machine learning is promising and we have a lab upstairs. I would say HVPG and liver biopsy still remain our gold standards, and we need to work at ILBS much more in this direction. Thank you for your kind attention.